The recently developed SMILE procedure has shown enough evidence to support its safety, efficacy, and long-term stability for myopia correction. Due to its potential advantages over LASIK, such as no flap-related complications, less dry eye, minimum post-operative restrictions, and possibly better biomechanics, it is becoming increasingly popular across the world. However, its effectiveness for astigmatism treatment has not been established yet. Studies comparing outcomes of astigmatism with SMILE versus LASIK showed suboptimal results with SMILE as significant undercorrection was observed over time. This was attributed to the cyclotorsional movements which could not be compensated due to the absence of an eye tracker and iris registration software by the femtolaser used to perform SMILE, which is currently one of the limitations of this procedure. These torsional movements are mainly of two types: static cyclotorsion due to a change in posture from sitting to supine, and dynamic cyclotorsion occurring during the laser treatment itself. In this video, we discuss some techniques and tips to refine the outcomes of astigmatism with SMILE and also break some of the myths to improve our understanding on this topic. Let us begin by first understanding the difference in cyclotorsional movements between LASIK and SMILE. It is noteworthy to mention that unlike LASIK, where both static and dynamic cyclotorsion can occur, SMILE shows predominantly static cyclotorsion. This is due to the eye being fixed with vacuum to the contact glass while the femtolaser creates the refractive lenticule. Other causes of cyclotorsion in SMILE can be tilting of the head, Bell's phenomenon, squeezing of the eye, application of speculum, activation of suction, and differences in the curvature of contact glass and cornea. Also in SMILE, as the centration of treatment is on the visual axis determined by the patient's fixation, an active pupil tracking system is not required, although iris registration would be helpful to compensate for cyclotorsional error. We hereby describe a simple and practical technique to manually compensate for the cyclotorsional movements in SMILE. This technique is based on a study by Shen et al., who showed that manual limbal marking was effective and reliable for treating astigmatism in LASIK in the absence of advanced iris registration software. In this method, the limbus is marked at 0 and 180 degrees while the patient is in upright position using a marking pen or a bubble marker. The accuracy of marking can be verified with the Toricam software. The ink used to mark the cornea must be infrared transmitting to prevent black spots, which are the areas of laser non-delivery. This can be verified by using the infrared light of the femtosecond laser. When the light is on, the ink marks should disappear as shown in this video. Alternatively, special epithelial markers may be used to give longer marks on the cornea at 3, 6 and 9 o'clock positions, obviating the need of using ink. The patient is then positioned under the microscope of the femtolaser and the limbal marks extended up to 2 mm into the clear cornea to enable their visibility after the cone is applied. Ensuring proper centration, eye is docked to the contact glass and suction is activated. At this point, the surgeon can determine the extent of cyclotorsion by noting the relative position of limbal marks in comparison to the horizontal axis of reticule on the right eyepiece or the left screen of the femtolaser. Cyclotorsion can then be compensated for manually by gently rotating the contact glass to align the limbal marks to the horizontal axis of the reticule. Following this, the active laser process is started to create the refractive lenticule, which is then dissected and extracted from the cornea. Another point that deserves to be mentioned is that the technique is safe as gentle rotation of the contact glass does not lead to inadvertent suction loss. We evaluated 81 eyes with clinically significant astigmatism undergoing SMILE procedure with manual cyclotorsion compensation. A 10% nomogram was applied. Intraoperative cyclotorsion ranged from 2 degrees to as high as 12 degrees. At 2 weeks, the mean astigmatism reduced significantly and remained stable until 3 months follow-up. All eyes were within 1 diopter of cylinder correction. Furthermore, the data was subjected to vector analysis, which showed that in both groups, mild undercorrection was observed, which may be a desirable outcome as overcorrection may be difficult to tolerate. Based on our experience, we recommend that all eyes with clinically significant astigmatism of 0.75 diopters and above should be marked. In eyes with low astigmatism less than 1.5 diopters, an intraoperative cyclotorsion up to 5 degrees is acceptable and no compensation is required. However, if the cyclotorsion exceeds 5 degrees, then manual compensation with the technique described is recommended. On the other hand, in eyes with high astigmatism of more than 1.5 diopters, any degree of cyclotorsion is significant enough to warrant manual compensation. In addition, using a large optical zone and a suitable nomogram may decrease induced aberrations and provide better long-term stability. To conclude, manual compensation of cyclotorsion may be a safe, feasible, and effective approach to refine the results of astigmatism with SMILE, especially in higher degrees of cylinders in the absence of automated iris registration software.